Good morning, everybody, and welcome to another webinar organized by the Academic Subcommittee of the GMOA. Today, we have Dr. Darshani Hettiarachchi, Consultant Child and Adolescent Psychiatrist from the Lady Ridgeway Hospital for Children in Colombo to discuss about early identification of child psychiatric conditions. She's a child and adolescent psychiatrist with a special interest and experience in managing child victims of trauma in both local and foreign settings. She also has a substantial experience by participating in teaching and training programs as a resource person in Sri Lanka, including the Postgraduate Institute of Medicine, Family Health Bureau, Health Promotion Bureau, Regional Director of Health Services Office in Galle, Ministry of Indigenous Medicine, and the Ministry of Education of Sri Lanka. Currently, she holds the post of Vice President of the Sri Lanka College of Child and Adolescent Psychiatrists. Over to you, Dr. Darshani, to take us through your presentation.
Thank you, Dr. Rajiv. First of all, I would like to thank Government Medical Officers Association for giving me this opportunity. So today I will be focusing on how to identify child psychiatric conditions at early stage. So let's see what are the mental health conditions which we see in children and adolescents. Mainly there can be neurodevelopmental disorders such as autism spectrum disorder, learning disabilities, learning disorders, as well as attention deficit hyperactivity disorder. So these conditions come under neurodevelopmental disorders, and the importance of these conditions is that they occur due to some deficits or changes in the developing brain, and it's very important to identify these conditions as early as possible and to start early interventions to see a better outcome. And other conditions what we see in children and adolescents are the anxiety disorders, depression, conditions like bipolar affective disorder, schizophrenia, eating disorders like anorexia nervosa, bulimia nervosa, and substance related issues. So considering the time factor, I will be mainly focusing on neurodevelopmental disorders, the symptoms and signs of neurodevelopmental disorders, and also anxiety and depression. So let's focus on autism spectrum disorder. I think it's very important to know about this condition because we commonly see it, and it's very important to identify this condition as early as possible, and it's very important to start early interventions to see a better outcome. So autism spectrum disorder is a neurodevelopmental disorder, and it has two main clinical features. One is the persistent deficit in social communication and interactions, and the second component is the restricted and repetitive patterns of behaviors and interests. So what are the features which come under poor social communication? These children can present with speech delay. Usually, a child should be able to speak 2 to 3 meaningful words by age 1, and usually they should be able to speak 25 to 50 meaningful words by age 2, and also by age 2 they should be able to combine 2 words together, and by age 3 usually they should be able to speak approximately 250 to 500 meaningful words by age 3, and by age 3 they should be able to combine 3 words together. This is the usual speech and language development of a child. So children with autism can have speech delay. That is one, and the other feature which comes under poor social communication is they may have speech regression, where by age 2 or 3 they may speak couple of words and then they stop talking these words also. That is called speech regression. And also sometimes these children can have echolalia, that is they tend to speak the same thing what we ask from them. For example, if you ask a child, "Are you hungry?" rather than saying yes or no, child might say, "Are you hungry?" That is a repetition of the same thing what they here. And other feature which comes under poor social communication is sometimes they can have their own language. We call it jargon language. So they may speak in their own language and which cannot be understood by the other people, but the parents might say, no, they have their own language and we can understand what they say. But it will not be a functional language for a child to communicate as a normal child. So these features come under poor social communication. And let's see what are the features which comes under poor social interaction. The features which come under poor social interaction are, these children may have poor eye contact and they may not have joint attention. That is, usually when we pass, when we are dealing or talking with a child, when we pass a ball to a child, the child might pick it up and send it back to us. But these children, they will not have this concept of joint attention and they will not play with another individual, or they may not play with the same age individuals. So those are the features come under poor joint attention. And also these children can have limited understanding about the social concepts, where they may not behave in a particular manner in a particular social situation. For example, when a child goes to a nursery, usually they know that they have to behave the way the nursery teacher asks them to do, or they know that they have to follow instructions, they have to go in a queue. Like those things they learn usually by looking at others. But those are the social concepts. But these children may not be able to understand the social concepts and behave in a particular social situation in an appropriate manner. They also may have deficits in imitative learning. That is, they usually children learn by observing other children, but they may not be able to learn things by observing other children. So those features come under poor social interaction. And also these children can have limited emotional reciprocity. That is, usually a children will be able to understand whether their mother is angry or whether their mother is happy by looking at the mother's face. But these children, since they are not maintaining eye contact, since they are having limited joint attention and this emotional reciprocity, they may not be able to understand the other's feelings, emotions by looking at their facial expressions. And in addition to that, these children may do same thing again and again and live in their own world. We call it restricted and repetitive interest and behaviors. So those are the common features of a child with autism spectrum disorder. So they may not have eye contact, they may have speech delay, they may not play with the same age children, they tend to live in their own world doing the same thing again and again. When they go to a nursery or other social situation, they may not be able to behave in a particular manner. So those are the features of a child with autism. I think it's very important for a medical officer's point of view to know about the etiology, because when you may not have to diagnose autism, but you may see so many children who have already been diagnosed by autism, and sometimes they may come to your clinic or to your practice or wherever, and then the parents might ask, why did this child develop this condition? Was this due to our fault, or whether this was due to the medication which I took during the pregnancy, or those are the problems or the questions the parents might have. So it's very important for a medical officer to know the etiology for this autism spectrum disorder. Actually, there is no exact etiology for autism spectrum disorder is identified. So there is a strong and complex genetic association that the heritability is 40 to 90%, as well as this genetic component is modulated by multiple environmental factors. So actually we only have risk factors. There is no exact etiology. So the risk factors are the male gender and family history of siblings or parents with ASD, and advanced paternal and maternal age, prematurity if the gestational age is less than 35 weeks, and if the mother, if the fetus was exposed to an antenatal infections and antenatal exposure to medications like sodium valproate, antidepressants, and genetic syndromes such as Fragile X syndrome, tuberous sclerosis, Rett syndrome, Down syndrome, muscular dystrophy, and neurofibromatosis. Children with these conditions are also at higher risk of developing autism. So what you need to know is that autism spectrum disorder doesn't have an exact etiology, but it occurs due to genetic and environmental factors, and there are multiple risk factors which can increase the risk of developing this condition. So what are the early warning signs for autism spectrum disorder? I think it's very important for you all to know the early warning signs, then it will be, you will be able to identify this condition as early as possible. The studies have shown that the autism can be diagnosed at months 18. So when the child is 18 months old, we can actually diagnose autism. So what are the red flag signs or the early warning signs? If a child at 12 months of age, not having cooing or reciprocal babbling, and no use of social gestures like waving or say tata bye at age 1, and also not having pointing to indicate interest in objects or people at age 1, and also if the child is not responding to their name by age 1. Ideally, child shouldn't have to respond to their name which appears in the birth certificate, but if the child is responding to the name, whatever they are called at home, for example, Baba, Puta, Suduputa, whatever the name they call the child at home, and if the child is not responding to this name at age 1, then it is an early warning sign. And also, at age 18 months, if the child is not sharing the child's enjoyment, like bringing the toys of interest to show to the caregivers, and also if the child is not having any meaningful words by 18 months of age. And by age 2, if the child is not having any spontaneous words or 2-word phrases and not having interest with other same age children, then those are early warning signs. And also at any age, if the child is not having eye contact, not responding to their name, and or if there is any developmental regression, then those are considered as early warning signs. So how are we going to assess a child with autism spectrum disorder? Actually, again, I have to emphasize the fact that to diagnose autism spectrum disorder, we don't have any particular investigation or blood test, any scan or any test is not available to diagnose autism. Autism has a clinical diagnosis. So we need to have a proper history, antenatal history to identify the risk factors, birth history, again to identify the risk factors, and the developmental history. In the development, we need to ask about these early warning signs, speech and language development, whether the child responded to the name, whether the child had pointing, whether the child had this emotional reciprocity, all these things, and saying tata bye at age 1. So we have to ask everything, all these things from the developmental history. And again from the family history. Again, the family history to identify, because I mentioned there's a hereditary to 40 to 90%. So if the family history, in the family, if there were anyone having features of ASD, then this child might have a risk of developing ASD. So the family history and other comorbidities and risk factors. In the examination, general examination, neurological examination, and as I mentioned earlier, to exclude any syndromes. So then we need to specifically look for the speech and language, eye contact, social interactions, and repetitive behaviors. So there, as I mentioned earlier, there is no specific investigation, but we do investigations to exclude other comorbidities. So how are we going to manage autism? Again, I need to emphasize the fact that there is no medication to treat these core symptoms which I mentioned earlier to treat autism spectrum disorder. Autism management, the most important thing is to early identify and start early effective interventions. So what are the interventions? It's mainly the behavioral interventions and occupational therapy, speech therapy, sensory integration. So there are treatment options. The behavioral behavioral management, but there is no medication to treat autism. That information is very important, because I mean, as a child psychiatrist or general psychiatrist, we see so many children with autism spectrum disorder who have been given many medications to control their behaviors, but actually the therapies are the mainstay of management. So in summary, autism spectrum disorder is a neurodevelopmental disorder which occurs due to some deficits in developing brain, and we can identify, or we can diagnose this condition by age, like 18 months of age. There are two main core symptoms: poor social interactions and poor communication, and also repetitive behaviors. So they can have early warning signs like poor speech delay, no eye contact, not responding to their name, not pointing, and not saying tata bye at age 1, also not living in their own world, not paying attention to other people. So those are the early warning signs. I think as medical officers, it's very important for you all to know these early warning signs and do the relevant referrals. And the other important point is there is no any diagnostic test to diagnose. Autism is a clinical diagnosis, and when it comes to the management, the main management approach is the therapeutic approach, like behavioral management, speech therapy, OT, sensory integration. There is no medication to manage the core symptoms of autism. So the most important thing is to identify early and start interventions. There is no wait and see option in autism, because sometimes we see children who were presented with speech delay and then seen by again the health professionals and send them back saying that this will improve with time. So whenever you have any doubt, it's very important for you all to refer the child to either a pediatrician or a general psychiatrist or a child psychiatrist. So that comes to the end about the autism spectrum disorder. And initially I forgot to mention that if you have any questions, you can put the questions to the chat box, and I can answer the questions at the end of the session. Now let's move on to the intellectual disability or mental retardation. What we call in this condition, what we see is that individuals have like limited intellectual capacity, or we call them slow learners in layman's language. So intellectual disability involves problems with general mental abilities that affect functioning in two areas. One is the intellectual functioning, that is learning, problem solving, judgment, memory, solving mathematical problems. So all these things come under intellectual functioning. And the other area is the adaptive functioning, that is the functions which are needed to live a normal life, the daily activities such as communication and independent living. So depending on the severity, the diagnostic classifications have classified this into mild, moderate, severe and profound. So what are the etiological factors for mental retardation or the intellectual disability? There can be genetic conditions and syndromes like Down syndrome, birth trauma, severe head injury, even severe birth infections, and even extreme malnutrition at very young age can lead to this, and infections like meningitis and exposure to toxic substances like lead. Again, this condition comes under neurodevelopmental disorder, and we do not have a medication to improve the intellectual functioning. I think sometimes we see some children who are coming with poor school performance. So this mental retardation or the intellectual disability may be one reason for poor school performance. Actually, they are so slow learners. The thing is, sometimes we see they have been prescribed many medications to improve their brain development. But I think there is no medication which can be given for a child to improve their brain development. So the main management is the occupational, depending on their disability. speech therapy, occupational therapy, family support and education, because it's very important to provide adequate family support and family education, because whenever a parent, because all the parents in this world, they want their children to function to their maximum level. So when they realize that their children cannot do their education to the expected level, or they have poor academic performance, then they get very worried about it. So that is one reason that they go from doctor to doctor for looking for a medication. So it's very important to educate them and support them, and also providing adequate social support for these families is also very important. Now we are moving on to another condition called attention deficit hyperactivity disorder, where we see children with hyperactivity. We call them hyperactive children. So there are two kinds of clinical features. One is the inattention, other one is the hyperactivity or impulsivity. In the symptoms which come under inattention are like they fail to give close attention to details or make careless mistakes at schoolwork. So when you look at their books, like they always have careless mistakes. Sometimes 1 plus 1 they might write like 5, or like very careless mistakes, and they may miss plus minus or things like that. And difficulty in sustaining attention, where they may not be able to maintain attention for more than 5 to 10 minutes. When we ask from them, they might say that even if they do, like when they are doing something which they really like, even they may stand up and go and come back in 5 to 10 minutes time, and they doesn't seem to listen when spoken to directly, and doesn't follow through instructions and fail to finish work. They always tend to, they are unable to finish a work. They tend to, they do not finish their work, and difficulty in organizing tasks, and avoid dislike to engage in tasks which need sustained attention. For example, when they have to do solve a jigsaw puzzle or something, they may try to avoid it because they can't maintain the attention for a longer period of time. And also when it comes to mathematical calculations, they may be able to just do pluses, minuses, additions, subtractions, but when it comes to lengthy questions, they may try to avoid these questions because they can't maintain the attention for more than 10-15 minutes of time, and they can lose things very frequently. They may lose erasers, pencils, all these appliances very frequently, and they get very easily distracted. For example, when they are seated in the classroom and another student's pencil drop on the floor or something, and they get easily distracted and will not be able to focus on their schoolwork, and they are very easily forgetful. What are the features which come under hyperactivity and impulsivity? They are very fidgety. It's like the machine is fixed into their legs, like always running here and there, and often leave seats in situations when remain seated is expected, and inappropriate running and climbing, unable to play or engage in leisure activities quietly, and often on the go, acting as if driven by a motor, talks excessively. Sometimes they may not be able to wait until they get their turn. For example, if the teacher asks a question from the classroom until from another child, if this child knows the answer, they can't wait until they get their turn. They may suddenly answer the question, and that is what the difficulty in waiting for turn, and interrupt or intrude on others. So these features come under hyperactivity or impulsivity. So if a child is having either features of inattention or features of hyperactivity and impulsivity, we can give the diagnosis of ADHD, but the symptoms have to be, the 6 symptoms or more have to be there, and the symptoms should be there for at least 6 months, and this degree is inconsistent with developmental level and symptoms present prior to age 12. And the most important feature is that most important fact to come to a diagnosis is that these symptoms should be there in 2 or more social settings. For example, if a child is hyperactive, disobedient, not listening to parents at home, but like usually when we assess the child, we always get information from the parent as well as from the class teacher, because we always, according to the diagnostic criteria, we always need these symptoms to be there in 2 or more social situations. Let me explain the reason for it. For example, a child is brought to us by a mother and says that this child is hyperactive, very irritable, not listening to the parents and always running here and there. Then when we get the report from the class teacher may say that very obedient, listening to the instructions very well and helping other children and no behavioral problems at school. So do you think that we can give the diagnosis of ADHD to this child? Actually, these behavioral problems may be secondary to the child's response to some sort of family environmental stressors. So vice versa. In another scenario, sometimes the child may be referred by the class teacher saying that child is very irritable, not fidgety, not listening to the instructions, not like disturbing other children and all the features of ADHD. But when you get the information from the parents might say, no, this child is very helpful, always listening to us, not hyperactive, even helping younger children in the family, so no problems at home. So these behaviors at school may be a child's reaction to some sort of environmental stressors in the classroom. Maybe child is being bullied, maybe victimized of abuse, or the teachers are very strict, or else child is having some sort of learning problem. So there may be so many reasons for this child's behavior at classroom. So that is why, rather than giving this diagnosis to a child with one having features in one setting, it's very important to get information from 2 social gatherings and to confirm that this child is having these behaviors in 2 or more social situations to give this diagnosis. And also with these symptoms, there should be functional impairment on this child, either in social, academic or occupational activities. So in this condition, not like in other neurodevelopmental disorders which I mentioned, ASD and learning disability, in ADHD there are medications which can help the child to improve the symptoms, like stimulants, so like methylphenidate, and non-stimulants like atomoxetine, and antipsychotics like risperidone, aripiprazole, and alpha-2 agonists like clonidine. So these medications can be given to manage the symptoms. But again, since this is a neurodevelopmental disorder, we do not talk about cure. We always focus on symptom improvement and improving the level of functioning. And in addition to medications, it's very important to focus on behavioral management. That is to improve the parenting skills, because you can imagine, I mean, you all also must be having children at home. When a child is very hyperactive and having disturbed behaviors, then it can affect the parenting skills. I mean, it can affect the parents, as well as sometimes the poor parenting skills can also lead to these or reinforce these behaviors. So it's very important to improve the parenting skills. And so the things which comes under parenting skills are like the parents should have like set boundaries in the family, and also always parents should be consistent when they are handling with child's behaviors. For example, if a child having demanding behaviors with phone addiction, so that is one of the common problems nowadays we are facing. So the child is having excessive use of phone, and when the mother tries to restrict it, and if the father is freely giving the phone to the child, then the inconsistency of parenting there, then the child will not be happy with the mother's control, and child will be more happy with the father, and then the family will not be able to control that child's behavior. So whenever we are handling a child's difficult behavior, it's very important for both parents to be on the same page and to be consistent in the management. And positive reinforcement of desirable behaviors, that is, usually children look for attention. So irrespective of the good attention or a bad attention. So usually what we do as parents is usually we give more attention to the bad things what children do rather than the good behaviors. So then these bad behaviors tend to be more reinforced and more sustainable. So what we always advise parents are to give more attention to the good behaviors what they do and ignore the undesirable behaviors what the children do. So those are the behavioral management we usually use in attention deficit hyperactivity disorder. Now let's move on to, so when we focus on attention deficit hyperactivity disorder, the most important point which I want to highlight is just having hyperactivity, just having disobedient behavior doesn't mean that child is having ADHD. These features have to be there in 2 or more social situations, as well as due to these symptoms there should be any kind of functional impairment for the child. And medications are there to improve the symptoms. So let's move on to anxiety disorders. So we commonly see anxiety related problems in children and adolescents, and these anxiety disorders share common features such as they share excessive fear and anxiety and related behavioral disturbances. Usually in anxiety disorders, individuals tend to overestimate the danger. For example, if a child is having a specific phobia towards a butterfly, but we can see that the butterfly is not harmful, but an individual who is having butterfly phobia will be very scared of the butterfly and they tend to overestimate the danger. And also this can be often associated with autonomic arousal and avoidance behavior. So they tend to develop features of autonomic arousal like sweating, palpitations, difficulty in breathing, trembling sensation, tension, headache, those kind of autonomic symptoms. And due to these symptoms and also the anticipated worries, individuals tend to avoid these behaviors. And anticipatory anxiety, where they start these anxiety and worrying thoughts and autonomic symptoms even after thinking about the situation. And due to this fear, they tend to avoid the situation, and which can lead to functional impairment. And the anxiety disorders are more common among females. So what are the anxiety disorders which we see in children? Separation anxiety, specific phobias like which I mentioned earlier, and the social anxiety disorder, and generalized anxiety disorder, obsessive compulsive disorder, and selective mutism. So what is separation anxiety disorder? In separation anxiety disorder, the children can have significant distress when a child is away from parents or another caregiver or home. So what are the main features? Recurrent excessive distress when anticipating or experiencing separation from home or attachment figure like parent or caregiver. And this persistent and excessive worry about losing or experiencing an unexpected separation from an attachment figure. For example, by illness, accident, disaster. Like usually we start seeing this separation anxiety when children start schooling or when they start going to a nursery, because that is the time they start getting separated from their parents, caregivers, or the attachment figure. So how they feel it is that they start having excessive worries, but like if they stay away from the parent or the caregiver, the parent might develop an illness or he will die from an accident. Those kind of worries come to their mind, and because of these worries they may start refusing to go away from the home, including to school or other activities, and excessive fear of being alone without the attachment figure. And sometimes they start refusing to sleep away from home or go to sleep without being near the attachment figure. And also they can sometimes experience nightmares about separation. So as I mentioned earlier, we usually start seeing these features when they start either going to school or when they start going to a nursery. it's perfectly okay for a younger child to start crying, worrying, being scared and anxious when they start staying away from their parents, especially when they go to school or nursery. However, these symptoms should resolve within 1 month of time. So if the child is persistently having excessive crying, worrying, difficult to stay away from school, parents and stay in the classroom, and which affect the functional level of the child, then we have to consider it as a separation anxiety disorder and need to start interventions. It's okay for a child to have these symptoms for less than 1 month. If the symptoms are there for more than 1 month and if there is significant functional impairment, then we have to start interventions. Especially the interventions are, we usually do not recommend medications. We always recommend behavioral interventions. And specific phobias, the same features, and in specific phobias, children can have marked fear or anxiety about specific objects or situation like flying, heights, animals, injections, blood, and the object or situation always provoke fear and anxiety, and again they can have anticipatory anxiety, and due to this excessive anxiety they try to avoid the situation, and again these symptoms should be there for 6 months, and there should be significant distress and functional impairment due to this. For example, if a child is scared about the injections, and if because of that, if the child totally avoid going to the hospitals, and since that total avoidance, if the child is unable to get the adequate care, then there is a functional impairment, then we need to intervene. So again, management mainly behavioral, and there are some medications also available. So, social anxiety disorder. Usually we see social anxiety disorder in older children and young adults. What actually happens is they have marked fear or anxiety about one or more social situations in which the individual is exposed to possible scrutiny of others. For example, having a conversation, eating or drinking or giving a speech. So, the main worry what they have is the fear of negative evaluation by others. So they are scared to speak in front of other people, or they are scared to do a presentation in a stage because of the fear that they will be negatively evaluated by others. So due to this, sometimes they facing these social situations always provoke anxiety on them, and because of that they try to avoid social situations, and the symptoms should be there for more than 6 months and should be there. They should have significant functional impairment due to these symptoms. Usually, I think I don't have to tell all of you, like we all have social anxiety. If we think about our medical student period, we didn't want to, I didn't want to, as a medical student, I didn't like to do presentations, but I think in 4th year, we all had to do a presentation. So since everyone, like none of us wanted to do the presentations, we had to put the lots. And then I still can remember myself and my friend, we were saying Ittipiso Gata because we didn't want to pick that this sheet and do the presentation, but we were worried, but still we somehow managed to do the presentation. So we all are having anxiety. It's perfectly okay for even children, adolescents, adults to have anxiety, but due to this excessive, and if the anxiety is excessive, and due to this excessive anxiety, if we are trying to avoid situations, as well as if there is significant functional impairment due to this anxiety, then we should consider therapy or medical management. In generalized anxiety disorder, children always they are worried about everything. For example, they are worried for each and everything. If the parents are at home, they may be worried about that something bad will happen to the parents. If they are outside the house, they may be worried, something bad will happen to them. Likewise, they are worried about each and everything happening in their life. Again, the symptoms should be there for 6 months, and they can't control their worry. Worrying is associated with autonomic symptoms, and again, results in significant distress and functional impairment, and these symptoms shouldn't be due to substance use or any medical condition or any other mental disorder. But this generalized anxiety disorder is very distressing for children because they can't it can affect, they are always in a distress and they can't enjoy their normal life, and it can affect their academic performance also. So they can have excessive and uncontrollable worry about the events, and often associated with physical symptoms like headache, muscle tension, restless, palpitation, GI symptoms like nausea, vomiting, diarrhea. And so the main worries they can have is performance and competence at school, personal safety and safety of family members, or they even worry about natural disaster or even future events. Again, the management is the behavioral, CBT and pharmacological. Now let's move on to the condition which we all aware, the obsessive compulsive disorder. In obsessive, because usually doctors always have obsession, the perfectionist traits, and are at higher risk of developing OCD. So we all have some features of obsessions and compulsions, but the thing is, if we can manage the symptoms and function normally, then we don't have to worry much. So in OCD, there can be obsessions and compulsions, or both. So what is an obsession? It is a recurrent and persistent thoughts, urges and images which are intrusive and unwanted and causes marked anxiety and distress. Individual tries to ignore or suppress it or neutralize it with some other thought or action. So what are the compulsions? Compulsions are the repetitive behaviors or mental acts performed in response to obsession with the aim of reducing the anxiety and distress. Just to explain, so what are the common themes of obsessions? Common themes are fear of contamination or death, needing things orderly and symmetrical, or aggressive or horrific thoughts about harming yourself or others, and unwanted thoughts. So for example, when we focus on fear of contamination, individual might feel that their hands are contaminated irrespective of how many times they wash their hands. And needing things orderly and symmetrical, sometimes young children I have seen, they have to put their school books in the bag in an order. So if they feel that they didn't put it in order, they have to repeat it. They have to do it again and again. And it's one example. And sometimes the individuals can have aggressive or horrific thoughts about harming yourself or others. I have seen some individuals that they avoid to go to the kitchen because when they see a knife, they get the doubt whether they stabbed someone. So sometimes when they are driving, they feel like whether they hit someone by the vehicle. So those are the horrific and irrational thoughts. And unwanted thoughts including aggression, religious, sexual subjects. And common themes of compulsion like washing, cleaning, checking, counting, keeping the things in an order, follow a strict routine and demanding reassurance. So those are the compulsions. So let me explain using a simple example. So obsessions are usually intrusive, senseless own thoughts, irrational. They know that they are senseless, and they try to stop the thought, but still it comes to your mind. For example, now just let me give you an example. Now you all must be sitting somewhere and listening to my lecture, but a sudden thought might come saying that your hands are contaminated with cow dung. But you know that it's irrational and it's impossible because you are sitting somewhere, you didn't get contact with the cow dung. You know that irrational. So then your brain says that no, this is irrational. But still, this thought is very strong and intrusive, and it repeatedly coming to your mind and arguing. Then at some point, because when you get a thought that your hands are contaminated, you always get the second thought to go and wash your hands. So in your mind, you are arguing, no, this is senseless. At the same time, the other thought coming, obsession comes and say, no, your hands are contaminated. So at one point, you can't stop this thought further and you go and wash because you are so anxious, and then you go and wash your hands. That is the compulsion. And you feel such a relief that now you got the thought that your hands are contaminated. Now you wash your hands. Now you have a relief. But then what will happen? Again, you will get the same thought. So if you continue the behavior, if you continue the compulsion, then it's going to continue. So there are medications, pharmacological and psychological. So let's focus on selective mutism, again another anxiety related condition which we see in children. They have normal speech and language development. They can speak normally, but they stop talking in front of places where they feel anxious or in places where anxiety provoking. So this is totally different from speech delay in autism spectrum disorder. In mental retardation, they have a speech problem, but in selective mutism, they have normal speech and language development, but due to the anxiety, they stop talking in particular social situations, but when they feel comfortable, they speak normally. Now let's move on to the last topic, that is the depressive disorder. What I thought of emphasizing this is because even though we think that children usually do not have depression, but we see so many children with depressive disorders. So what can be the common symptoms? Like they can be sad, they may be withdrawn, they may have irritability and anger, they may have low level of energy, they may have lack of interest and enjoyment in usual day-to-day happy things, or they may lose interest in extracurricular activities, they may have poor self-esteem, self-care, poor attention concentration, which can lead to declining academic performance. They can have either poor sleep or excessive sleep. They can have low appetite, and sometimes they overeat and complain of somatic symptoms like headaches, stomach aches, and sometimes adolescent can start using substances as a way of self-medicating. Some children, even when the symptoms become severe, they can go up to suicidal ideas, and these symptoms should be there for more than 2 weeks and should be a functional impairment to come to the diagnosis. But what I want to highlight here is these symptoms and the presentation of depression in children may be vary depending on multiple factors, and especially depending on their developmental ages. Young children may not come and say that they are depressed. They only have behavioral changes. For example, they may be angry, irritable, behavioral problems. So most of the time, children with depression can come with behavioral problems. In addition to that, we see many presentations with unexplained somatic symptoms ended up as depression. So we get many presentations, referrals from pediatric wards with unexplained somatic symptoms. Actually, they are depressed. The main problem is actually they are having depression. So management is again the medications and the psychological management. So as I mentioned you earlier, even though there are many child and adolescent psychiatric conditions, due to the limited time factor, I only thought of discussing these areas because these are the conditions that you can identify early and start early interventions to see a good outcome.
Right. Thank you very much, Dr. Darshani. I think we have 2 questions from the audience. So I'll go to the first one. The first question is, any advantage of stem cell therapy in autism spectrum disorder, and is stem cell therapy available in Sri Lanka?
First thing, still it's in the process of research level, and currently we do not have that therapy in Sri Lanka. So what we advise is mainly to focus on behavioral management.
Right, and also we have another question, is agoraphobia associated with autism spectrum disorders?
Yes, because children with autism, it is a very good question, because children with autism are at higher risk of developing mental health issues, anxiety, depression, even conditions like psychotic conditions. So they can have anxiety related conditions. So agoraphobia is an anxiety disorder. They can have agoraphobia. The problem is sometimes depending on the symptom severity, we might not be able to identify whether this is clear agoraphobia or whether this is like their behavioral problems secondary to their communication problems or their poor social interactions, or whether this is due to RRP. So depending on the level of the severity, sometimes it may be difficult to diagnose, but yes, children with adolescents with ASD can have agoraphobia.
I think Dr. Darshani covered the main topics that we should touch on pertaining to the psychiatric issues in children. So the doctors who are working in the peripheral hospitals, I think, would have got a clear idea about how we could approach a child with such conditions and when to refer and what are the cutoffs in the ages where you can diagnose such conditions. So this presentation will be recorded and will be available on GMOA YouTube channel as well, so you can use that for reference, and you can always contact any of these specialists in the tertiary care units in your provinces as well. And Dr. Darshani, if you could tell me in which districts or provinces are the child psychiatrists available so far?
So far, we have 2 child and adolescent psychiatrists at Teaching Hospital Ragama, one in the university side and the one in the ministry side. And we have another child psychiatrist at Teaching Hospital Kalubovila. And we have 2 child psychiatrists at Lady Ridgeway Hospital, one at NIMH and one at Teaching Hospital Karapitiya. But all these child and adolescent conditions are treated by general psychiatrists. So if you have any doubt or if you feel that this child is having some sort of a psychiatric condition, you can refer these children to general psychiatrists. The general psychiatrists are there at based hospital level, and also we have MO mental health. I think so. If you have doubts, again you can contact the MO mental health and get their support as well.
Thank you very much, Dr. Darshani, for that expert opinion, and I think all the doubts have been cleared. So that concludes the webinar for this week, and I would like to thank everybody who connected with us and responded by sending us questions as well. So we will meet you in another fortnight's time, and that's goodbye from the academic subcommittee of the GMO. Thank you.